Hi, folks. Welcome, welcome, welcome. Can you believe that we are in our fourth session? I'm Carol Bortman, and I'm representing the group that put Don't Be Scared, Be Prepared together. How are we doing so far? I think so, too. Today, I have a couple of announcements. First of all, there will be any handouts that you want, like in session 3, which is Bob Vincent, session 2 and session 1, and today, you can get as many handouts as you want in the pastoral offices. So don't ever hesitate. They are there. Please come and get them. The second thing is that some of you may have had a hard time going on, watching on demand on the TV, especially the last session, which was session 3, which is responsibilities, Bob Vincent. The problem was not yours, not mine. The problem was something to do with the watch on demand on the TV. So they are working on it. So keep going on, and soon, I don't know what that means, but they're going to be fixing it. So just keep going on, because I know it's important to watch these videos on TV, and they're working on a solution as fast as they can. Today, we have medical choices, which should be fascinating for you all to listen to. I'm going to introduce Barbara Blanford, who is in charge of this group, and she will make the comments about this session. But it's great to see you, and hang in there, guys.
Good morning, I'm Barbara Blanford, and welcome to our 4th program of our year-long series, Don't Be Scared, Be Prepared. This series focuses on proactive planning and communicating with your family and loved ones about your wants and needs around end-of-life issues. None of us are going to get out of this alive. I'm glad I got some laughs to that, because if I didn't, I was going to say that's a big reason we're having this program. Nobody likes to talk about it. We have covered estate, legal, financial issues, as well as organizing important information so that those we leave behind will be able to settle our estates. Today's presentation is on medical choices for medical care and support around acute and chronic illnesses. It does not have to be end of life. It can be starting now, because we all have medical issues. Our presenters are both from Brooksby Medical Center. We have Dr. Aliza Acker Bernstein, though I think she goes by Dr. Acker with us, who is the medical director of Brooksby Medical Center. And we have Caroline Sims. She is a licensed social worker working out of the medical center now since, I believe, last summer. She's not well known unless you've been over there, so it will be interesting to have her present today, and you all will get to see who Caroline Sims is. I'm going to turn this over at this point to Dr. Acker, but I would like to say there are no handouts yet for today's program. Caroline has been doing them, and she's still making some corrections, but they will be present at our next meeting. So with that, I'll let Dr. Acker take over.
So my daughter-in-law's sister is an architect and has started a program you may have seen written about in the BBC in the last 3 weeks, which is called the Urban Death Project. And she is working on a different format of burial, to put it very bluntly, a format of composting human bodies respectfully, so that one would bury someone in a central place, after a short period of time, end up with something that is given to the family, which is essentially earth with remains, and then something meaningful can be planted. And her slogan for this is, "Wouldn't you like to be a lemon tree?" So one day, not too long ago, I was walking with my son, my grandson. We had gone to get ice cream. And while my grandchildren were running around, my son turns to me very seriously and says, Mum, I really want to talk to you. And I'm sure all of you have had this experience. My heart drops to my toes. My God, he's getting a divorce. One of my grandchildren's are sick. My daughter-in-law is dying of something unknown, and I hadn't noticed what's going on. And I try not to show any of this on my face, and I say to him, you can talk to me about anything you want. And he says, and he says, and he stands on one foot, he stands on the other. And slowly I get the meaning he wants to talk to me about my death. So I say to him, sweetie, would you like to ask me if I want to be a lemon tree? So yes, I am comfortable talking about death and dying. Many of us are not. It takes time. Ask me if I really deep down believe that I will die. I will tell you probably most of the time, no. I think this is theoretical. Just in case, like I wear a seatbelt. I am never going to be in a car accident, but I wear a seatbelt. I think that's as close, as best as I can do with this. I think for all of us to do what we can to make the process more reasonable is a good thing. We live, in some respects, in a wonderful time. We can do a lot, though not everything, about suffering, illness. Ultimately, we can't do anything about death. Eventually, we will all die. The fact that we can do a lot doesn't mean that we have to do everything at every given moment. And when not to do is a very, very personal choice. And it's a tough choice to make for all of us. It's a tough choice for me to advise you. It's a tough choice for you to make. Truly, I view myself as an advisor. I can do my best to explain what the possible outcomes will be. But I think I've told many of you, when I graduated from medical school, they didn't hand out crystal balls in my year, none. So I can't actually say what will happen in any given instance. I can give you best statistics. That's what medicine is built on. We do pretty good with that when you look at it. I mean, most of us have been sick. Most of us have been treated fairly successfully, sometimes not. But most of the time it's been successful based on statistics. But it is not a given, it is not always. So part of my job is to be as good as I can in explaining this. Part of your job is to make the best decision you can with the information you have. None of us will ever have absolute information. It just doesn't exist that way. Very, very small, minute times can I absolutely say, right? You've just cut your wrist and blood is pouring out in a pulsating rhythm. I think you have just cut an artery. Yes, if we don't stop it, this may cost you your life. That is very clear, messy but clear. Often, it's not as clear. And waiting for things to be absolutely crystal clear isn't necessarily going to help. And don't tell me you haven't done this in your life. Most of our lives, we make decisions based on what we know now as best we can. This is no different. Medicine, illness, chronic illness that could get worse, that might get worse, that did get worse, is no different than deciding to drive today when it's snowing and possibly slippery out. Make the best decision we can. So I go back to not doing everything. Why not doing everything? Because people quality of life matters. And I don't think you would be here if that wasn't part of what you think. Just breathing in and out is not enough. And we are in a point in medicine where we can create situations where someone is just breathing in and out. Where do we draw the line? Where is the line in the sand? Again, it's different for everyone, and it's different under different circumstances. So today is not about absolute, but definitely about thinking and communicating. First, communicate with ourselves. Do I have lines in the sand? What would they be? Right? It's easy perhaps to see something huge. So if I'm attached to every possible machine and cannot communicate, and this from here on out will be my life, it's easy for me to say, no, I don't want that. What if I'm only attached to a couple of machines and I can communicate every other month? Is that good enough? And I'm deliberately exaggerating. And we want to think about treatments. And we used to say, many of us, well, if I need chemo, I won't want that. But many of us have changed our mind about that. Chemo used to be very harsh. It still sometimes can be very difficult to go through, but doesn't mean there isn't a favorable outcome. So again, we always look for this kind of absolute, and it's hard to find. Caroline, can you put a most up, please? Thank you. Okay. So, part of preparing is looking at this document called the MOST, which is a medical order for life-sustaining treatment or not. This is a Massachusetts legal document. So though, as your physician, you can give me verbal instructions and I can try and follow them, this is a compelling legal document. I would urge you to make sure you have one. I would urge you to update one if you have one. And I want to go over the details because they are not necessarily intuitive. So if you look at the MOST, the way it's put up here, it's 2 pages. The first page is the one on your left. That page must be filled out in order for this to be effective or helpful. That page has only 2 choices for each question: yes and no. So the question basically on this page is, if my heart were to stop and my breathing were to stop, would I wish to be resuscitated? So in effect, someone says, we have seconds to make a decision. So can't call a healthcare proxy, can't have a discussion. Yes or no, quick answer. If this is not filled out, by default, we're a full code, meaning we will be resuscitated. Resuscitation consists of potentially electrical shock to get the heart restarted, pumping the heart either manually or with a machine. When the ALS ambulance arrives, there's a compressing machine that will do that. Putting medications through an IV to hold blood pressure up and maintain kidney function. Putting a tube through the mouth into the lungs on a breathing machine to help us breathe. That's a resuscitation. Essentially, if that has succeeded, we now might be on a breathing machine, on these medications, and hopefully off at some point the compression machine, because our heart will have restarted. If we haven't said no in a legal format, the answer is yes, and that will happen. For some people, many people, the answer is no. If I have reached the point where my heart stops and my breathing stops, say many people, that's my line in the sand. I don't care why it happened. I don't care if you could get me back. If I've already walked half a mile in that direction, I'm going to take the journey. Some people say no. Do what you can for me. What you have to realize with this is that what we can make a big attempt at is to return a pulse and breathing. What we cannot guarantee in any way, shape, or form is what the quality of life will be after this is done. There is no way to know, and this is speaking from personal experience, when something like that happens, what the outcome will be. If we were very fast on the scene and we moved very quickly and we had good reserves for the person who is undergoing the resuscitation, the outcome might be very good. As we mature in years, our chance of resuming the state we were in prior to this event lessen. Because basically we have less reserves. Less brain cells, less ability for the heart to come completely back. But again, it's a personal decision. Now the way this is stated, it says, you can say yes or no to resuscitation, referring only to what happens to the heart. And yes or no to ventilation, referring only what happens to the breathing. I will tell you again, from knowledge and experience, that if both your breathing and your heart stop, if we only take care of one, we're unlikely to get where you want to go. So if the heart and breathing stop and I give you oxygen, but the pump won't take that oxygen around to the rest of the body, it's not going to be very effective. So ask me why it's put that way. Because there are unusual circumstances, because people feel strongly about one versus the other, because it's different in children. Children whose heart stopped and breathing stopped, if you fast and you give them oxygen, may come back. It's not the same for adults, or less likely. So, do or do not do a resuscitation, do or do not do a ventilation. Now there's a trick question with the breathing one. Under the ventilation, there is a question, would you like non-invasive ventilation done? I find that a misleading question. It refers to a CPAP. But what we need to know about a CPAP is it doesn't ventilate, meaning it doesn't breathe for you. You must be breathing in order to be able to use a CPAP. So when is it good? If you can breathe but not very effectively, then we can use a CPAP, which is only a mask, does not require a tube into the lungs, and we can push air more effectively into you, and by doing so also help not allow the lungs to collapse completely at the end of your exhalation. So we can keep breathing going better. So these are two separate questions. You can't actually logically say, I would like to be ventilated in a non-invasive ventilation, and assume that the non-invasive ventilation, i.e. the CPAP, will actually breathe for you. So the answer is, do not intubate, do not use, or don't use. The last question on this paper says, transfer to the hospital or don't transfer to the hospital. It's a very broad question. It says transfer to the hospital only for comfort, or transfer to the hospital, period, no matter what the situation is. Now let me remind you, anytime you are conscious, you can choose something different than you've already put on the piece of paper. You're the boss. This applies when, for whatever reason, we can't have a conversation with you. Who would not choose to go to the hospital? Now let's not be too clever about this. None of us want to go voluntarily to the hospital. I understand that. But let's say we were sick. Some people feel that the hospital is a lot more risk, so that if they're unconscious and unable to make choices, they don't want to go to the hospital, where other people will continue to make choices without their input. Fair enough. Some people who are at the end of life do not want to spend what they have left of their life in a hospital. They want to spend it with their loved ones. So the answer is, no matter what the situation, don't transfer me unless it's for comfort. So that is the first page, yes or no. When we look at the second page, we're going to have more options. The options are, do what we're talking about, don't do what we're talking about, do it for a short period of time, undecided, and not discussed. So I'm going to tell you right now, since I'm taking all this time to discuss it with you, you cannot fill out none discussed. It's no longer an option. I would actually like to implore you not to fill undecided. Undecided means that if this decision must be made when you're not conscious and you're not able to give input, that whoever you've given the authority to make decisions for you, who will now be in a very unhappy place in their life because you are not able to communicate and are very ill, must also make a decision that you couldn't make yourself, and must guess at what you might have wanted. So let me implore you, don't put them in that situation. For better, for worse, make a decision. The two top questions refer to the first page. If you have decided you don't want to be ventilated, it says refer to first page. If you have decided you don't want a CPAP, it says refer to first page. If, on the other hand, you have said, yes, intubate me, or yes, use a CPAP, the question is, how long for? Now, please note that this very cleverly doesn't give you minutes, times, hours, days, or weeks. It says for a short period. A short period implies that whatever intervention we've put into place, we are expecting this to end and not to need this for the rest of our lives, however long the rest of our lives are. So if we said, yes, intubate, we are not saying we agree to live on a breathing machine from here on out. we are expecting whatever catastrophe led to this situation to end, at which point we will stop or you will stop the breathing machine. That's a short period of time. Why is it not bounded by exact time? Because we don't know the exact situation. So if the reason that someone required intubation is a very severe pneumonia, we expect the pneumonia to get better, then to be able to take you off a breathing machine. But I don't know how long. And how silly would it be if the pneumonia is going to take 5 days, but this says 4.5? So we go down the list, and it asks about dialysis. And this is truly about lines in the sand. So if the kidneys are not working and we need an artificial way to cleanse the chemicals in our body, we might have to use artificial dialysis. So some people go, okay, kidneys fail at some time for some people, and they go Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, and have dialysis. I have friends who do that. Looks okay, I'm okay with that. Other people say, no, this is my line in the sand. If I need dialysis, the answer is no, I'm done. Even if it costs my life. That's the question, right? No dialysis, even if it costs my life. Some people say, well, if you can do it for a short period of time, my kidneys come back and work, I'm okay with that. What could that be? Well, there are toxins that specifically might affect the kidney. And if we have been unfortunate enough to have those in our blood, we might be saying, if we do some dialysis, we'll clean these toxins out and then be able to keep you up dialysis. We expect that the kidneys will return to close to their normal function. How long? Well, it depends on the toxin. Same answer. Maybe 1 session of dialysis, maybe 5. And if you say 3 days, hey, it's a little bit ridiculous because it depends what it is. How about artificial feeding? There are 2 formats of artificial feeding. One is a tiny little tube that goes down from the nose right into the stomach. That we can only use for 2 weeks because otherwise we rub the esophagus too much, our food pipe, and it gets sore. And then we must make a little hole in the tummy and feed this way. Now, you could say, that's my line in the sun. If I can't eat and drink properly, that's it, I'm done. No, thank you. Someone else might say, why would I need it temporarily? Well, if I had radiation to my neck or an injury to my neck, put everything back together, but it's going to be a few months before I can use my esophagus properly, would I be okay with a feeding tube for that period of time? The answer may be yes, the answer may be no, but that's the type of limited use of a feeding tube. Then we come to artificial hydration, meaning fluid. And I'm sure many of us have experience of becoming dehydrated for one reason or another, or being in the hospital for one reason for another, like surgery, not being able to eat and drink, and having IV fluid. Now again, this is a little misleading in the way it's put, because essentially we can't do long-term IV hydration if we don't have a place to put the fluid, i.e. if we've said no to a feeding tube, so there's no tubing to go in, we won't be able to sustain IV for a long time. But some people definitely will say, yes, if I'm dehydrated, absolutely, for a short period of time, give me my fluids, hopefully I'll come back and no need for further issues. So we fill that out. We reach the bottom of the page. We reach the bottom of the page, and there are a few lines. It says, anything else you would like to say? Now let me explain. This is very tempting. Do not go back and qualify any of the questions that have been asked. So don't go back and say, if it's Monday, you can intubate me, but no other day. Or, if you will use pink tubing for my IV fluids, by all means. Not that. It's something that can be explained in 2 to 3 sentences very clearly that is personal to you and has not been asked about. For instance, if someone is a Jehovah's Witness, they might put on those 3 lines, under no circumstances would I wish any blood or blood products. It is very clear. It means even if it kills me, I do not wish blood or blood products given. Very clear, not a lot of sentences. Someone might feel that because they're a very Orthodox Jew or religious Muslim, they would not wish any grafts done with pig skin. Again, very clear. No pig skin grafting. Something medical. Sadly, let's say someone has really bad diabetes, has had one leg amputated. They fear that if they're unconscious and need another limb amputated, people will go, they agreed to the one, they'll probably agree to the other. For them, this is the line in the sand. So they write, even if I were to die, I do not wish any other limb amputated. Very clear. Very specific to them. No way to put it on a questionnaire like this. That's what it's for. Most people don't have something to put there, so if you don't feel you have to. Now, if we look at the form, we'll see that it requires the person to sign it, a medical provider to sign it, so an MD, PA, physician assistant, or an NP, nurse practitioner, needs to be dated and timed, and other details like phone number given. The other piece that's important here is who is signing the document, because it can be signed by the person themselves, which I would encourage you to do now, or soon, not this minute, not while I'm talking. That would be rude. It can be signed by a healthcare proxy or legal agent. Which brings me to the other very important topic. So we have a couple of ways to have someone be our spokesperson when we can no longer make our wishes understood, or we cannot understand the question. So if we're unconscious, we can neither communicate nor can we make it clear that we have understood questions. So we can have a healthcare proxy. We could have a power of attorney that includes health issues, or we could have a healthcare proxy. Massachusetts will no longer allow us to walk down a decision tree. So there used to be a situation where if one didn't have a healthcare proxy or one didn't have a durable power of attorney, we could ask family members with a decision tree which one we asked next. That does not exist. So the only third possibility after healthcare proxy and a legal power of attorney in Massachusetts would be to go to the courts and get a temporary guardianship. So again, I would very much encourage you to fill this out or legal power of attorney, because What you don't want is someone you love having to rush to the court to get legal guardianship when everything is going wrong, right? This person you choose is the person who you feel would best be your spokesperson, understands how you look at life, and would therefore make choices that you would feel comfortable with. So I give the following example. I am vegetarian. Not all my children are vegetarian. However, I would expect them, if I cannot make my wishes known, not to force me to start eating chicken. So it's not the choices a healthcare proxy would make for themselves. It's what they believe the person they're representing would choose. It's not the same thing, right? So one of my children might feel that to keep me alive is what is most important, but what they need to do is, if I've said do not resuscitate, is not to change that because they want me around. So it's not what they want, it's what they believe I would want. So sometimes the best person, often, is a family member, but sometimes the best person is not a family member because you feel that this would be too much for them. There is no requirement that it be a family member. But it does need to be someone that can be easily accessible. So if the person you would choose lives in Antarctica and only has connectivity to the outside world 3 times a year, you'll have to find someone else. Usually choose a healthcare agent and a secondary. Let me encourage you that the secondary not be someone in your own household. Why? Because someone in your household you're likely to be with, and God forbid you're in a car accident, it is likely that you will be with your spouse. So let it be someone not of the same household, who you have the same feeling about, that they would step in and do it as you wish. If, like me, you have more than one child, I have 4, still designate one to be the primary and another to be the secondary. If you want to put them all 4, by all means, but designate one. From experience, if you have 4 people who have equal decision making, it is very difficult to make decisions, and it's very difficult to treat you. If I have to call 4 people and have 4 separate conversations in order to decide yes or no to give you some IV antibiotics, this can become almost intractable. I'm speaking from experience. So make one an alternate, and if you want, you can have 4 alternates. Doesn't give you room here, but you can certainly add it. This requires also a signature by a witness. And just to remind you, at Brooksby, any employee of Brooksby or Erickson, we are not allowed to be witnesses on these type of documents. The reason is simple. One, if you were leaving any money to the Brooksby Fund and then I was signed on it, that might be suspicious, because I'm a very suspicious character. So please, these are 2 very important documents. They should be on your fridge. They should be with all your family members. They should be in your doctor's office, any doctor's office you go. And let me give you another piece of advice. Please do not hand your last copy to any medical institution personnel, including and particularly me. We will lose them. It's not deliberate. So make sure you have as many copies, and then when I say to you, I don't have your healthcare proxy. You go, I gave you one. Don't get annoyed, just pull out another one. And the ones on the fridge should not be the last document you have. They're there to take with you when you go unexpectedly out by ambulance. Now, if you haven't had this conversation with your family or your healthcare proxy, please talk to them about whether you would like to be a lemon tree. It helps. And one way to do it is to pull out these forms and say, look what I have done. Aren't I clever? This is what I mean. When I fill it in, this is what I mean by this. This is why I made this choice. This is why I made this choice. So that when the healthcare proxy needs to make a decision, they have a better idea. So if your children want to talk to you about your death, you've given them permission. You've also given some protection, if you will, emotional protection, to your healthcare proxy, who might be one child out of 4. Because you don't want the rest of them to be at their throat for making certain decisions. Or maybe you do. Let's assume we don't. This also, perhaps, should help you think about what type of things are reasonable to you, whether you're dying or not, because we don't know when that might happen. We don't know the circumstance. But to think a little bit forward and say, there are things I think are reasonable, there are things I think are unreasonable. How do we go about this? What are my feelings? What are my thoughts? What's important to me? It's another place when you fill out the forms to talk with your own physician about how you feel in the same way that you do with your family. Now, if you've put do everything and you change your mind, you can. If you've put do nothing and you change your mind, you can. When would be a situation? There's certain types of surgeries that will put you on a breathing machine. And so the surgeon may say, I see you have a DNR, do not resuscitate. Can we withdraw that for the length of surgery? So you say yes, if you've agreed to the surgery. Say yes for the length of surgery and then put it back in place. Fair enough? So again, these are not absolutes. There are times, even in chronic illness, where we reach a tricky point, where in order to treat, to make things a little better, we must, for instance, not treat pain. So we can't always hover over both. Often, many times, we can do both. Treat an illness, treat pain. Treat the discomfort, the nausea, the vomiting, and treat the illness. But sometimes we reach this watershed where both are not necessarily possible. Or where treating pain might risk life. That's the other reason it's good to have these thoughts in advance and put some effort into going, where would I be on that line? If the line is treat pain, for instance, treat illness, where do I hover? I don't say you can get an exact answer, but understand the question is out there and one that you might need to look at. not everything is treatable. In fact, many illnesses are not, but they're controllable up until the point that they're not. And we have a concept in our world somehow, in our Western culture, that says if we don't do everything, we're giving up the fight and we're wimps. Like everything else. Sometimes it's true, but often it's not. So not doing what would keep us alive despite everything isn't necessarily giving up the fight. It's a choice. We make many choices in our life. This is going to be another.
Thank you, Dr. Acker. We're going to take a 5-minute break so you can stand and stretch your legs a little bit, and then Caroline Sims will be talking with us. Thank you very much. Pardon me?
Introducing Carolyn Sims.
Thank you. I'm so happy to be here. Some of you may not know me. I am the medical center social worker here at Brooksby Village. I started in October of 2017. I actually came here for probably a lot of the same reasons you all did. There are so many resources here in this community. There is so much to know about being active, having quality of life. You have a lot of resources and a lot of support built in here, and I think that's just great. A little bit about me. I do counseling here in our medical center, and I'm also here to support IL residents and the rest of the community when things get really tough, when there's a crisis on the horizon, when you may need to start engaging other supports, your family to help you out. I work in the medical center. You might see me all over campus. If you're interested, I have some brochures that can be available if you're interested in what I do and a little bit about who I am. I do have a hospice background. I came from Care Dimensions before I started here. I worked in assisted living facilities, independent living, patients' homes and hospitals. Prior to that, I was with Elder Services, and my master's degree is in gerontological social work. So you are my population of choice. I'm happy to be here, and I'm a resource to you as well. So don't hesitate to call the medical center to get in touch with me. I am listed on the bottom here as one of the providers. We've got 3 doctors in our medical center. Dr. Acker, who you just heard from, who's our medical director. We've got Dr. Mulder. He's a longtime physician here at Brooksby. Dr. Patel, he's also board certified in hospice and palliative care and geriatrics. We've got Dr. Tuck, who's our podiatrist. Sarah Robertson, she only does 1 day in our clinic, and she does a lot of time over in continuing care. She's our nurse practitioner, as well as Sue Giles, nurse practitioner. Christine Cudahy is a nurse practitioner who spends most of her time over in continuing care. You may have met some of these people. Some you may not know at all because you may not be a member of our medical center. But I put these names up here so that you all know who's available to you. And a lot of what this presentation is about is your choices. And when things start to get difficult, when you start to be weak and kind of, bogged down with different symptoms from medical conditions, chronic or otherwise, I just want you to be all aware that there are options for you. And a lot of people choose to use our medical center because of the convenience factor. It's here on campus. Our docs are great. Our nurse practitioners are great. We're here to talk about the hard stuff and help you get more quality in your life. That's one of my goals too. I'm really not about how long I live. I want it to be good. I want my life to be full of quality, and I think this is a great series. I'm so happy to be a part of it. Thank you all for having me. I also want you to know that we have some specialists who visit our medical center on a regular basis. I will remind you all that this list is going to be available in the slides that you can get probably by no later than next week up in the pastoral care office. We have a cardiologist who's in our office twice a month. That's Dr. Kurzarok. He's part of North Shore Cardiovascular. He's leaving. This just in. Okay. Well, I'm sure those of you who are his patients.
Sorry. He is retiring. He's going to have someone else from his office come out. So it will be meeting someone new, but we'll still have a cardiologist here. Sorry about that.
Thank you, Dr. Acker. We have a dermatologist who's at our office twice a month, an orthopedic surgeon. He is with us once a month, and a chiropractor who's in our office just about every Wednesday, a half a day. Again, these are great resources if you're unable to get off campus to go to some of your specialists. I will be talking more about how to get off campus if you're not driving any longer. I don't want that to be a barrier. We have transportation options available here. But if you choose to make another choice, we do have specialists who visit just in Town Center and our medical center. Some of the things we've been focusing on in our medical center having to do with your care are the three things I've mentioned here. Annual wellness visit, you may have heard a little bit about this or had one. Myself and Sue, the nurse practitioner, are currently doing them. It's considered a well visit, not a sick visit. So you can come, it's covered by Medicare. And the idea is to start thinking about and addressing some of your goals as a patient and some of the things that might be getting in the way of you achieving your goals health-wise. And I think it's a good way to open up a conversation of what can you do to optimize your health, be more successful, and start engaging the supports that are here for you. We have a chronic care management program that is also through Medicare, and it allows us as providers to basically bill Medicare for what we're already doing, which is coordinating your care, talking to each other, talking to your specialists, talking to your families. It's considered non-face-to-face, but it helps tie things together a little more tightly. And really that's something that needs to happen, especially in this age group. Some of you may have 5 physicians you see when you include all your specialists, and it's good that we all talk and we all know your updated medications, what's going on with you. Advanced care planning, this is a lot of what Dr. Acker was talking about. Meeting with the providers, myself included, to talk about what you want. And if you're ready to fill out some of those forms, you can do that with our providers. The MOLS does need to be signed by a medical provider. I cannot sign one, but I think it's really important for all of you to have these documents on file with our medical center if you use them. And again, you can find out more information about these things in our medical center. Ask away, and you can refer to the slides when they become available. I wanted to breeze over palliative care and hospice care as part of some of your options. It's a choice that you might make at the end of life or towards the end of your life. And sometimes it's confusing because palliative care and hospice care can at times be used interchangeably, and they are not the same thing. So in a nutshell, palliative care is really for patients who are living with advanced illness and are seeking symptom management. They may not be looking for end-of-life care. They may not be ready to sign up for hospice yet, but it allows a specialized medical team to oversee your care, discuss goals with you, and really focus on symptom management. A lot of that might be pain management, dealing with stress, asking questions about where to turn when things start to get more complicated with your health. And this is covered by Medicare and most insurance plans. If you're thinking about this as an option for you, I would certainly discuss it with your physician. I know locally Care Dimensions does have a palliative care program, so that might be an option. Hospice is really for people who are facing a life-limiting condition and the prognosis is 6 months or less. So oftentimes, you may have your own physician certify that if you have a chronic or other illness that, should it take its natural course, you may die within 6 months. It's more likely than not that you'll die within 6 months. You could qualify for hospice. You also have to have the hospice physician at time of admission look over your record and say, yes, if the course of your illness goes as planned, you will more likely than not die within 6 months. There are some questions I put up here that actually come straight from the Care Dimensions website. Have you or your loved one seen a progression of serious illness? Have you had repeated trips to the hospital? Increased episodes of pain? Several falls in the last 6 months? Significant unexplained weight loss? Have you started spending most of the day in a chair or in bed? Have you had shortness of breath or difficulty breathing? Have you started to feel that treatment is becoming more of a burden than a benefit? These are some of the questions that people start to ask when they consider hospice. And this is, again, all about comfort and quality of life. And it's a personal choice. It differs for everybody. The goal of hospice is to provide comfort when a cure may no longer be possible. And the approach is team-oriented and includes not only symptom management, but emotional and spiritual support. Hospice is covered by Medicare and most insurance plans. We talked about the healthcare proxy and the MOLST, which copies can be found in our medical center over in Town Center. You can also find them online, and you may want to discuss with your elder law attorney if you have one to make sure that you can complete these with them as well. But if you're looking for the forms, please come to the medical center. We can give you blank copies. One of the other things I wanted to start touching on was resident life and some of the ancillary services both on and off campus for when things start to get more difficult. Perhaps you came here when you were much more active, when you could still drive, when you were out walking all the time, and then things start to slow down as they do naturally. There are so many supports and resources here that you may not know about. So I wanted to take the time to talk about some of these things so that you can engage them as you see fit or as you need them. Resident life, the suite is located in the Kingsbury Clubhouse. That's sort of the hub for a lot of stuff that you might need to learn about: community resources, fitness and wellness, pastoral care, visiting nurse services, home support, resident service coordinators. I put the number up there, so if you have questions, that's a good place to start. And all the staff here will point you in the right direction if they don't know the answer to one of your questions, but please ask. That's how we know things. A little bit about our fitness center, something that may keep you well or keep you more active, more mobile for longer. There's a couple of different memberships. What I found interesting is that there's a basic plus membership, $15 a month, and this allows you to use the fitness center, and they will help transfer you on and off cardiovascular equipment. So they can provide you with hands-on assistance if you're in an EMV or if you're using a walker and you need some hands-on help getting on equipment. Don't let that be a barrier to not going and getting some exercise. We have aquatic classes. We have what they call land classes, which are located in the exercise room over in Kingsbury. They have an amazing calendar. They have a great description of all different classes. Classes are pretty small, so, try it out. See if you like it. I think it's a great way to try to stay active, maybe meet some new people, and, be well for longer. Home health care. So you may hear the term certified home health, or at Brooksby we call it VNS, which stands for Visiting Nurse Services. Out in the world, out of Brooksby Village, we often call it Visiting Nurse Association. So this is staffed by registered nurses, physical therapists, occupational therapists, home health aides, and speech therapists. This is a skilled service and it's paid for by insurance. It's short-term, intermittent. It must be ordered by a physician, and you must be considered homebound. Here at Brooksby, homebound is the whole community. So you may have interfaced with certified home health when you've come home from a rehab stay, possibly from the hospital, and you have visits from a nurse and a therapist and maybe other disciplines. It doesn't last forever, and they decide their visit frequency, but it's a good way to make sure that you are being as safe as possible in your home. Sometimes they can make recommendations about equipment to use, and they can communicate with your doctors and other practitioners that are involved in your care to make sure that you are stable when you return home or after an acute event. Medical equipment, lots of questions about this. So some medical equipment is covered by insurance. I ask that you discuss this with your doctor because Medicare's rules change all the time, and it's not necessarily indicated that you might get something for free or covered based on what the criteria is for your illness and how you're using it. The Mason's Help program, I'm not sure if everyone's heard of that. It's the hospital equipment loan program. It's fabulous. So you are here in Peabody, you can feel free to use it. The website is there as well as the phone number. They're open from 9 to noon in Woburn. It's a loan program. So say you're coming home from a knee replacement and for whatever reason you don't qualify for a rolling walker, you can go borrow one. And you borrow it with the idea that you will return it when you no longer need it. They have a storeroom of different medical equipment. They don't teach you how to use it. It's just there for loan. You must be able to pick it up, but it's a good option for people that just want to have something short term or who maybe can't afford it. In addition, I'm sure many of you know that you can visit Amazon online, Walmart, or Walgreens for everything from raised toilet seats to rolling walkers, canes. But again, discuss it with your doctor. See how you're using it. Make sure you're using these things properly. Make sure they're fitted in your apartment properly. Oxygen. There is criteria for home oxygen use. Perhaps Dr. Acker could enlighten us on what that may be. Some people have portable oxygen tanks that they use with them. Sometimes people have
So, to have Medicare or insurance cover oxygen, you need a diagnosis, obviously, that requires oxygen. A broken elbow will not qualify for oxygen. So we look either for lung reasons or cardiac reasons. There's a list of these things, but Medicare usually wants us also to qualify you by how well you're oxygenating. So if you remember the test we do very often when you come to the doctors, we put something on your finger. It looks at how well you're oxygenating. Another way to do a test is a very specific blood test, which is used less and less. There are two qualifications for that. Either your oxygen is below a certain level at rest, or it drops if you exercise, meaning you walk. Or there are certain other degrees, for instance, if the diagnosis, for instance, if you have certain types of heart disease, you might qualify for oxygen even though your oxygen saturation is higher. So essentially it needs a qualification. And we need to have those tests done. Sometimes they're done in the hospital, and that's good enough. And if not, they can be done in the office.
Thank you. Home support. Many of you might be using home support or may have used it in the past. This is either privately paid for and added to your monthly Brooksby statement, and the cost varies by service and amount of time you use. You may know that there are some new requirements. There's a minimum of 2 hours. They can serve you up to 24 hours a day at home and independent living. You may also want to look into your long-term care insurance policy if you have one. This is something that you can start using for home support. It's not just for skilled nursing care or long-term care in a nursing home. There are some qualifications you need to have in order to use it and have it be reimbursed by your policy. But this is something you might want to look into if things are starting to get difficult for you at home. Some of the things home support can help out with, they have nurses that can do wound care, medication management, medication administration, care coordination. Sometimes if you have an adult child who lives out of state, you can hire a nurse to come to a medical appointment with you, take notes, report back to your adult child. They have home health aides who can do everything from light house cleaning, spring cleaning, escorting to medical appointments, escorting to other places on and off campus, medication reminders, meal prep, and help with personal care. This can be everything from hands-on care to supervision. It really depends on what your needs are. I highly encourage everybody to consider Brooksby Home Support. Should you start feeling like you are needing more help at home, don't be afraid to ask. It's better to start using the supports that are available to you rather than waiting for a crisis or a fall or something that could potentially be dangerous. There are some meal choices that a lot of people use when they come home from the hospital or are just not feeling well. You may know that there's campus meal delivery available from Green Tree, and there's takeout available as well. You can visit the ericksonresident.com website for menus. You can call the numbers and get delivery to your apartment. You can also have an aide or a family member get you some meals if it's getting too difficult. And I also advise you to please discuss this with your resident service coordinators, because sometimes it's hard to get down to the dining room. You're not feeling up to it, and there are options so that you don't have to go hungry, which can definitely affect your overall health if you're not well nourished. Housekeeping. Many of you are at a point where you don't want to clean your house anymore, and that is fine. Brooksby has housekeeping available. You can have it every 2 weeks or every 4 weeks. They do everything from carpet cleaning to changing linens, kitchen and bathroom cleaning. Sometimes this is how people are getting hurt. They're dusting, they're vacuuming, they're bending over to pick up crumbs, and something happens. And there are options like housekeeping here to keep you safe and to keep you from having to do too much that might be overexerting yourself. Intermissions is another great resource we have. It's a structured social day program. They use therapeutic experiences and fun activities to provide memory support for individuals who are experiencing some memory loss or confusion. This program is specific to Brooksby only. They take just about 11 people per day. It's located in Canterbury Court. There's a charge of $66 a day. You can try it out, see how you like it. And there are also some adult day health programs that offer some similar experiences off campus. Again, ask your resident service coordinators. There's a lot available. But what's interesting about intermissions is that not only does it benefit the person who's attending the program, it may benefit the caregiver or spouse. It allows that person to have some respite time, go do some errands, get some work done, go to a medical appointment, and you know that that person is safe and cared for and in a structured setting where they're going to get attention they need. I've been talking about the resident service coordinators. Here are their pictures. We've got Kara Smith in Town Center, Marina Gigliello in Kingsbury, and Lindsay Luffman in McIntosh. I know it's been a difficult transition as they used to be called social workers. They wear a big hat. They do a lot for our community, and they're a great resource. I think when in doubt, if you don't know where to turn, please go to them. They are available to support you and guide you, answer your questions, help you take the next step in whatever thing you're considering at the time. And they're good to know. If you're having concerns about a neighbor, you might want to go to them. If you are worried about an upcoming surgery or something is going on with you, please let them know. There are some community services here available outside of Brooksby. You may know about North Shore Elder Services. They're based out of Danvers, but they cover Peabody. There's the Peabody Council on Aging, which some of you may attend. or just go once in a while. They've got great programs. Adult Day Health, again, it's for some folks that might have some cognitive impairment or some other difficulties health-wise. It's a day program. There are a couple in the community and surrounding communities. There's hospice agencies, which we touched on earlier, who can help people age and die at home the way they want to. They have a lot of supports included in their breadth of supports. There's the Center for Healthy Aging. This is located in Danvers. It's affiliated with Leahy Hospital. And currently we are referring some folks over to the Center for Healthy Aging for psychiatric support. They have social workers, nurse practitioners, and psychiatrists on staff. They're a great resource. You may want to talk about it with your doctor if you're interested. They have a great website online as well. Private duty nursing agencies. We talked about how Brooksby Home Support has nurses that you can hire. There are a few other agencies in the local area that you can hire a nurse to do a skilled service for you at home. And there's home care agencies as well. You may see aides all over campus. Please ask your resident service coordinators if you don't know where to start. These companies all do relatively the same thing. They're competitive, but their goal is the same, and that is to honor your goals and to help you at home. We have a lot of support groups on campus. I've listed them for those of you who may not know. One thing I did not know is the Neighbor to Neighbor program. If you are recovering from a surgery or injury, you can call Lois Silverstein and she can arrange for someone to do a friendly visit, pick up your mail, something simple. We've got pastoral care services. Their office is right upstairs. We've got a chronic pain support group starting soon. Please reach out to me if you have any questions about that. We're looking for members. And again, these will all be available on the slides if you need to reference them, or you can find them on the bulletin board. Brooksby Transportation, many of you probably know the shuttle that goes around campus, the complimentary shuttle that goes off campus, and we have the car hire, which you can call the transportation office and have a car ready for you for an appointment or something else that you need to get to. It is important to start using and getting used to using these services for those days that you might feel weak or for that day that you decide to stop driving. We have options here, so don't worry about it. There's also Project Mobility, which is an amazing resource. It's through the Peabody Council on Aging. It takes Brooksby Village residents to weekday medical appointments on a shared bus. It will only take you to and from appointments in Beverly, Peabody, Salem, Danvers, and Lynn. The fee is a $1 donation each way. I see the bus, so I know people are using it. $1, that's amazing. It's much cheaper than a taxi. You may have to wait, you may have to be on a bus with other people, but it's gonna get you to your off-campus appointment. You can call 2 months ahead or no later than a week in advance. I know they book up quickly, so think about this as an option. There's also the ride many of you use. I see the bus here as well. I've put the website. There is some criteria that you have to go in and apply in person. That's a fairly new regulation because of some fraud in the system. They want to see you face to face and approve you, but they will take you to their headquarters and bring you back in their van. And then you can use it for whatever you want. The eligibility for the ride doesn't depend on the nature of your disability. It has to do with whether or not you can use public transportation. We don't have the T here in Peabody, so the ride is really your lifeline to getting places, and you can use that any day of the year. What I wanted to share is that if you've had a medical emergency, your licensed healthcare provider, so your doctor, can request 30 days of the ride for you that starts immediately. You can continue to use the ride after the first 30 days, but you do need to apply. So if you're undergoing some procedure and you're not going to be able to use your vehicle, or perhaps you're on a medication that inhibits your ability to drive, you may want to talk to your doctor about temporarily signing up for the ride so that you can get to your follow-up appointments. I've put all the information about setting up an appointment, having an interview, and getting a decision. It usually takes about 3 weeks, and they have to schedule the in-person interview. So if you're thinking about it, call ahead now. There's also a new resource in the community right at home. The caregiving agency is using Lyft, a rideshare service. You don't have to have a smartphone to use this. They will take you anywhere, to appointments, to do errands. You don't have to tip, and typically the cost is 30 to 40% less than a cab service. You can go with a caregiver, you can go alone. You just call them at their number Monday through Friday, 9 to 5, and tell them where you want to go, and they will pick you up, and they will send you an invoice in the mail. So you don't need to have a smartphone, but it's another great way to get around the community for whatever you might need to do. I know I covered a lot. Please ask questions. This is our question and answer time. And don't forget that I'm in the medical center. I can be reached at the main number. My name is Caroline Sims. Thank you all for having me, and thank you, Dr. Acker. And I am looking forward to hearing your questions.